Hello, everyone. Welcome back to Hot Seat. I'm Omid Moghaddas, joining you from Tehran, and I'm so grateful again to be with you all from this educational platform, especially in these days. And I have to say again, I'm so blessed that one of my dear friends, Filipe Lopes, accepted the invitation and is joining me now, and he's with you all on Hot Seat. Hello, Felipe, and welcome to Hot Seat. And thanks, buddy, for accepting the invitation.
No, Omid, actually, it's my pleasure to be here, and thank you for your kind invitation. And let me just give you congrats on that because you've been developing this Hot Seat initiative. Man, this is really awesome because you gathered uh, the top clinicians from all around the world, and this is really amazing, and it's amazing to now be part of it. And thank you again for your kind invitation, and I hope all the people that are watching us will enjoy the presentation as it's a dear topic.
I'm sure they will. And actually, for all people are watching right now, today we have a very great topic on Hot Seat, and the topic that Felipe wanna present for us is the one protocol about immediate load with final restoration from single crown to full arch. And one stands for one natural aesthetic. So it's a new concept, and I'm so happy to have this platform for sharing this concept with all of you through his amazing presentation. And as a tradition, I would like to first have Felipe's CV for all of you, and then I will shorten my talking and we'll go straight to the presentation. And at the end, as a routine, we will have a discussion on the topic. So he had his dental degree in Oporto's Dental University, in FMDUP, member of BTI's International Scientific Committee, CEO of the Portugal Implant Dental Center, CEO at the Centro de Medicina Dentária de Braga, if I'm spelling it right, and CEO of EIP, which is the Expert Implant Therapy Study and Research Group, clinical teacher at the Oporto's Dental Medicine University in Portugal, BTI's Advanced Oral Implantology Courses teacher, EIT's Advanced Perioplastic Surgery Courses teacher, and EIT's Advanced All Ceramic Rehabilitations teacher. He is a member of the Scientific Committee of the Dental Magazine Scientific Pro, author of several national and international lectures, author of the book Dental Materials, in its 15th edition in Oporto's Dental Medicine University, and exclusive practice in orthodontics, oral rehabilitation, and implantology. And also I have to say that he's also one of the authors of the multimedia book, Soft Block Treating Severe Recessions Around Dental Implants. And me personally had the honor to have a little part of his amazing work in this book. So with that said, I would like to thank you again, my friend, for accepting, and we are looking forward for your beautiful presentation, and the platform is all yours.
Okay, thank you, Omid. And by the way, your Portuguese is excellent. You did it. You said some of the words in Portuguese, and it was excellent. So let's try to start off here. Let me just share the screen. Let me know if something goes wrong, okay?
Yeah, sure.
So it's a pleasure for me to be here, and I hope that we get back to, and really fast, to the old normal, because I'm missing being all around. And as Omid said, we met on the Dental XP platform. This was actually my last lecture. It was in Atlanta on Dental XP Global Symposium, and when everything was about to break, the world was about to stop. So it's a pity that we did, but hoping now and driving to better days. Today's topic, as I said at the beginning, it's dear talk to me, and it's all about immediate load with the final restoration. And to kind of give you a roadmap to my presentation, and I'll try to make it interesting in the way that it will be always together with clinical cases. We have a first part that will show you how it all started. Then we will go to the ideal one protocol cases. What are the cases that you can select and do sorry, the one protocol? And this is very, very important, as we know. Also, and the third part will be much about the basic biology. And this is so very important when approaching this topic. And we'll be looking at material types, shape, and also roughness, a particular part of the roughness, the nano roughness, which is so important. And also, the fourth part will be one abutment, one time, and taking it a little bit beyond what we know. And we like to call it the implant extender concept. And the fifth part, that'll be with some clinical tips on a lot of those cases where the one protocol was performed, and particularly let you know that the CAD CAM has been quite an important tool in approaching these cases this way. So let's see how it all started. Well, in fact, it all started 7 years ago. And 7 years ago, I had this case that we did orthodontics, minor orthodontics, just to align and to get the teeth in the right position and space to put some implants in. And in this case, we decided we're taking off an orthodontic mini implant, and we decided we had enough bone on width, not that much on height, but it was a soft bone, and it was the available bone was enough for us to place 2 implants each quadrant. And what you're watching here is an incisionless, flapless surgery of this case, where we're placing 2 implants, and see how deeply we are placing these implants, because this is also very, very important. You are moving them away from the mucosa almost 4 millimeters, so you must calculate that. Also on the second quadrant, the same kind of surgery with a much more limited space, but enough space for 2 premolars. We do pretty much the same. Look how deep, you can look at the transporter of the implant, look how deep it goes. So we had measured before the thickness of the mucosa, which is something very, very important, as we will see. We did an impression directly to the connection of the implants, and this is something that we also keep in mind because it's going to be changing. We used CAD CAM, as you could see, because it's so much easier now for us to help our technicians to build our crowns and final restorations the way they should be built. And the next day, this was not the same day, but then the next day, I'm just making a small incision to get access to the implants. As you can see, it's not even healed yet. And I'm just making a small incision, and without raising a flap, just putting it away for me to go in with the final crowns that were made on zirconia, which is also very, very important. And we'll get to see that along the presentation. And so now we're screwing them, and the insertion and giving it torque for them to be inserted. At the other quadrant, we did exactly the same. So just taking out the healing caps, You can see 1 day after surgery, taking out the healing caps, and directly, we don't do it now directly to the implant connection. This was the first case. And we just raise a little bit the mucosa just to provide enough space for you to place the final restoration that you had been designing before milling and the CAD/CAM software. So, so very, very easy, and you get this nice result. So this is 6 months after placement on the first quadrant, and this is 6 months after placement on the second quadrant. And even as time goes by, you can see that the healing is absolutely amazing. So it was, we ended up with a beautiful end result. So the question now is, what are the ideal one cases? Because it's a huge responsibility for you to decide to go straight to the final restoration, because if something goes wrong, it's going to be much more expensive. So it's a huge responsibility. So the question is, what kind of cases can I start with? What are the ideal cases for the one protocol? Because if we think it a little bit, we can think of partial extraction therapy, I would say, immediately socket shield. And what is that? Well, it's simple, because as you preserve the periodontal ligament and the blood supply with PET strategy, and that's why PET and socket shield are being so popular. It's because you get almost no bone resorption. You get a very, very reduced tissue collapse, and that's awesome. So if you have a case where you predict not to have tissue collapse, well, you can just go ahead and design your final restoration in a much easier way, because you know that those issues won't change all around your implant and all around your crown. And in fact, I wrote in 2019 with Maurice Salama and Bernardo, I wrote a paper on CAD/CAM International magazine. And to our knowledge, it was the first paper ever written with a socket shield case and a final restored with immediate load and a final restoration. And this is available for free in the internet. You got the link below, so you can go through it. And the case was this one that I'm presenting here, the one protocol. It means 1 day natural aesthetics. That's what we're trying to and what we're aiming to. It means that we can immediately restore patients with the final restoration. And so here you can see there was an inferior premolar. You can see some details of the CAD design, and we can, if you want to, you also can scan this QR code, and you'll go to the multimedia article that me and Maurice also wrote, and Bernardo. So you are watching. We're splitting the root. We're going to take the lingual part of the root. You all know how it is. We have to completely separate the buccal part. You have to thin the buccal part and then remove the lingual part. In this case, what we did, now we have better tools to do that. There was an occlusal perspective of that, and with a big round burr, there are other burrs now that do even a greater job than it was done. This is now 5 years. It was the pictures are from 3 years, but it is now 5 years. And it was published, when it was published, and the pictures that you can see at the article, they got 3 years old. So it's a post-op of 3 years. Here you can see the detail. You have the buccal part of the root, and now you're ready to extract and remove the lingual part, and then go ahead and place your implant. This is a unit. This is a unit crown. So we're placing the implant, but in here we're changing something a little to something a little bit better than before. In this case, we put a transepithelial abutment, which means we're not going to connect the crown directly to the implant's connection. We place the implant, and as you'll see in a second, you can see the implant and its internal connection. You can see that he is way under the bone, and we're now placing the implant extender. We call it the implant extender, an immediate abutment that we're placing on top of the implant. And now we're taking the impression of that abutment. So after doing it, we can now go to the lab and using, this is a PRGF. We are placing only PRGF in the gap, in the surgical gap. As you can see, PRGF in the red. It's being placed in there with no other bone material or bone graft. So no biomaterials, just the PRGF from our patient. You can have the glimpse CAD/CAM design and fabrication. So we do it once we think our crown is inside the parameters that we defined for it. Well, just 16 hours later, we have our final restoration prepared. And so we're ready to place the final crown. And our final crown, ready to go in. We screw it with 20 Newton centimeters torque in this case. Other cases, we will screw it with another kind of torque, as you see later. This is a post-op view, and another post-op view. This is 8 days. This is 50 days. So it heals beautifully. So it's like a natural tooth that has always been there. But the great thing is that 3 years later, and you can see it here, that's the pictures that you can see in the article. 3 years later, you can see how the buckle looks so nice. And you have an implant on the molar, and you can see that it's a little bit more depressed, the mucosa adjacent to molar when compared to the premolar. So 3 years later, the surprise, or what we were expecting, is that you got bone well above the implant abutment junction. So you can see the implant, you can see the IHA, and you can see that well above that, you have bone and you have a stable interface over there where bone is grown well above that implant abutment junction. And we'll see how biology behaves, why biology behaves in this way. So why is it ideal? Well, it's ideal because of what we've been saying, because it's easier to predict tooth shape and position if you have a socket shield case, and you have all the references to build the teeth adequately. So it's an advantage because we all know that when we extract a tooth, we have to expect tissue collapse. And it's not all about just collapse. When we talk about tissue collapse, we talk about phenotype change and thickness loss. And we'll go a little bit into that. Because as you can see here, we lost 2 dental units, but it's not just collapse, it's phenotype. You got a different gingiva and you got a different thickness from what you get all around those teeth. So it's serious. And we know that when we extract a tooth, in terms of mid-facial recession, we can go as bad as 1.5 millimeters of recession from several studies. And we can go And what means labial palatal change? Come on, labial palatal change can be as big as almost 6 millimeters. That's a big change. That's a big change that we have to face. So it's important that we know this in advance. And we also know that we can treat collapse, but we are trying to run away from collapse. This is the soft block, for instance, as Omid mentioned. I wrote a book on the soft block. Scan this QR code. You can go to the multimedia book later. But we want to run away from this. We don't want to have to graft. We can treat collapse, as in this case, we had collapse by, you have a fistula also because that canine and premolar at because of fractures and recementation. But you can see all the collapse that we had on those implants, on those molars and premolars and molars. So we had to take out the implants and we had to place new implants. And we can do that. 3 implants extracted, and we had 4 implants placed because also we had to extract the canine and the premolar. We had to do some GVR also. So, and it was big GVR, I mean, mainly horizontally. At the same time, we placed the implants, but we want to run away from this. That's what we want to do. You can see the GVR on the left with the provisionals restorations, and you can see it on the right. So we have solutions for collapse. But what we want is to try to get away from that and to try to avoid that. And if collapse, again, we can treat collapse if it is severe collapse. And I invite you all also, and I have the opportunity here to publicly thank you, Omid, to you and to Amin Motamedi, because you did this beautiful work on bright dentistry too. It's a multimedia article. You can scan the QR code and go to the multimedia article. And they have absolutely amazing and severe cases. I mean, 3D complex reconstruction. And it's beautiful to go there and see what they've done. So we can treat collapse, but we know how collapse is. And what we were asking with the one protocol is how to decrease the collapse risk. That's where we're aiming at, is how to decrease the collapse risk. So it's time for us to go a little bit deeper into basic biology and talk a little bit about that, because we know that soft tissue sealing and support around dental implants, that's one of the things that we have to end up with. It's a soft tissue sealing that's good for implants health. And that will depend on these factors, on the plaque zone, adherence zone, and also on the connective tissue thickness, but also buccal volume, buccal bones volume and support around dental implants is very, very important. And we are now seeing how important it is to preserve the bundle bone that always goes away if you don't preserve the root. That's why socket shield and partial extraction therapies are so popular, because they allow you to do that. Whenever you can perform them, you really can preserve bundle bone as in no other way possible. And we know also the importance of being inside the bone envelope, and that has a final repercussion on implant's position. But also we should not forget about the fact that the connective tissue stability is very, very important to the bone. That's very, very important. So there is a soft connection to the bone. So let's get into a little of basic biology that we all should know around dental implants. We know that one of our arch enemies is plaque, and nothing will adhere to plaque. And knowing that, we have to move it away from our implants. Yes and yes, that's what we have to do. And every time we have an implant exposed to the oral cavity, we should know that we always have a plaque zone. That plaque zone is going to be about 2 millimeters, sometimes less, but well, on the worst situation, you'll have 2 meters. So count on that. It's 2 millimeters. And also, the ideal adherence zone has to be 1 millimeter at least. So, and that's not surprising when you go back and you read one of the most important studies ever. And I mean, this is a human study. It's a controlled clinical trial from our big friend Thomas Linkevich's. And in his study, he found out, and it's a human study, so this is very, very important. He found out that if you add a soft tissue thickness around your dental implants of at least 3 millimeters, you would not have almost bone loss. And this is simple. It's because you made enough room for both of these zones. Because you have having 3 millimeters vertical thickness, you have room for the plaque zone and for the adherence zone. That's why. And even he found out something even more interesting. That is, even if you place your implants 2 millimeters above the crest, it doesn't matter. It won't do you any good because you'll get bone resorption if the mucosal thickness is below those 3 millimeters. And even if you do the platform switching, which is awesome, and it's a magnificent tool, it won't do you any good if you don't have those 3 millimeters mucosa around your dental implants. And this is very, very important knowledge. So strong soft tissue sealing and support around dental implants depends on some of important factors that we should know. It depends on mucosal thickness, and we can graft and increase it, but also it depends on soft tissue's histological connection to implants, to abutments, and to crowns. And this is so very important. Let me repeat it. Histological connection to these three elements: implants, abutments, and crowns. And also you have mucosal thickness. So we have to take care and be aware of the nano roughness of these three surfaces: the implant neck, the abutment, and the gingival part of the crown. And so let's try to see a little bit more about it. So we have a back zone of 2 millimeters, it's always there. And the adherence zone needs to be at least 1 millimeter. And I say at least because what? Because can you increase the adherence zone beyond 1 millimeter? That's the question. Is it possible to do? Well, I think it's one of the bases of the one protocol. In fact, you can increase the adherence zone, and you should increase as much as you can. So as you can see here, the other molar had, the previous molar had good issues. I'm comfortable with those, but I'm way more comfortable with this. And this is interesting. This is another thing that we published, the original bioprofiling, because you can increase the distance of the plaque zone to your implant's neck, which is the most noble biologic part that we have in our implants. You can see it here. We have on the right, you can see the same implant with a 2 millimeter intermediate implant extender abutment. But also you can see, and you'll see it on a movie just right away, you can see that you have developed an horizontal adherence zone of 2 millimeters, 4 millimeters, 5 millimeters, and even 7 millimeters. And why we say so? This is the original bioprofiling, which you can find on Dental XP. You can see that there is bleeding there. As soon as you remove the individualized healing cap, you can see bleeding. Well, we know that epithelium vascularized. The epithelium gets its vascularization from the connective tissue. So when you take it out, and you're gonna see we're taking it off the individualizing healing cap, and you can see bleeding all over. So what you've just done was disrupting the connective tissue adherence that you developed over there, and this is very, very important. So how is it possible for us to modify healing? Because this is very important. How can we do it? Can we do it? Well, there are three known ways for you to modify healing. The material you expose healing to will do a lot of difference, as we know. If you put an implant of gold, you won't get osseointegration. So the type of material is very important. When you expose healing to some kinds of materials, you'll get different results. The shape of material, the shape of the material you expose healing to, you expose your body to, when it's healing, it's also gonna influence your end result. And also, and this is something that we are discovering in this last decade, the nano roughness of the material. It's not just only about the material itself, it's also its nano texture. And on this topic, it was quite game changing, this article, because it was the first human histological evidence produced by our good friend Myron Evans also in 2008. And he showed that it was possible to have connective tissue attachment to titanium. And this is really important knowledge for us to know, because up until this date, 2008, we thought this to be mission impossible, but it's not. Depending on what kind of nano roughness you expose your implants to, it's possible for you to have it. And let's see a case and where we how important also one abutment, one time concept, which has been there for decades, almost 30 years now. And from Abrahams and Linde, one abutment, one time, it's absolutely amazing the things that you can do if you do one abutment one time and you are able to extend your implants. Let's see this case. You can even see a recession on the buccal of this tooth that I'm extracting now. And I'm calling your attention up onto that because it's very interesting that you see that I did nothing of soft tissues and they improved quite a lot. So I had to extract these teeth, and it was not possible to do socket shield. Otherwise, you know how I would do it. I would do a partial extraction therapy for sure. So preparing the location, our implant site, placing the implants, see how deep they go. And I think there is now, you are seeing the transporter of the implant. They are really deep in the bone. And now we're placing, this might have like 5 millimeters length abutment and the other 4 millimeters length abutment. We're torquing the abutments, the implant extender. We now do the impressions. And after doing the impressions, this is also very important, the CAD CAM. When we do CAD CAM, we're now able to help out our technician in performing the final restoration. In this case, it was provisionals, okay? I did not do the final restoration, but actually this was one of the cases that impulsed us to go for the one protocol. So we're just putting the PRGF in the gap, in the surgical gap. You can see the model, and you can see the provisionals, CAD-CAM milled the provisionals, and the provisionals in their place after a couple of days. Let's go and see out of it. This is 8 years after. This is 8 years after. Look at that recession on the second premolar. It's gone, and I nothing. Just just went biologically. That's all. But the most important thing is yet to come, because look at this. Look at this bone morphology, the implant extender. Well, but it could be a one-dimension X-ray. So we took CBCT, and we can see that the bone goes well beyond and stays stable the implant abutment junction, because what you're seeing there, it's abutment. It's not the implant, but it's an abutment in titanium with a certain nano roughness. And this takes us to another very, very important article from Nevins. This one, it's an animal article, not a human histology. This is histology, but it's related to, and it also changed our way of thinking. It was quite mind changing to read this article, and it was in 2010. And basically, if you add CT fibers going, the tissue fibers going perpendicularly to our abutments, well, you could eliminate the implant abutment junction. You could have bone growing up to your abutment. And this is very, very important knowledge for us that deal every day with implant dentistry. So we have connective tissue adherence and bone growth to the abutments also. And this is important to know. So it depends basically on the nano roughness you expose your tissues when they are healing to you. With this kind of implant extenders, as I like to call them, you can have osseo and tissue integration. So your soft tissue sealing is going to be much stronger if you do the one abutment, one time concept from Abrahamson from 1997. Go figure, 1997. So, and it's unbelievable. And when you go to the RS review, there are some very nice conclusions, because if you, they saw that the fibroblast insertion to the abutment surface is capable of eliminating the physical gap between the soft tissues and transmucosal components. And this is very important to keep your implant safe and your implant abutment junction. That's why bone grows over the IAJ. That's why. And also, if you have perpendicular collagen fiber organization, that's going to be better. And you can see it also on Myron's histology in humans. And this can be achieved if you expose your tissues to the right hydrophilic surfaces, to the right nano roughness. So the one abutment, one time concept, it's important to follow it, because disconnection also and reconnection of implant prosthetic components may disrupt the things that you've been building in terms of soft tissue, and not only on soft tissues, I would say. But we've been talking about connective tissue and bone. But what about the epithelial attachment? Well, epithelial attachment is also very interesting, and Linkevich's has been doing some very good stuff, scientific stuff on. And thank Thomas if you're somewhere there listening to us, because it's been very, very useful, all the science that we're getting from you. And this is 2017, and we found out that zirconium oxide provides lower addition for bacteria, so we have less plaque accumulation, better proliferation of fibroblasts, and reduced probing deaths if you use zirconium. So it's the machine zirconium. So one of the best things that you should tell your technicians to do is not to glaze the zirconia that's going to be exposed to the epithelium. Otherwise, you're killing it. If you glaze it, You're just wasting one of the most important properties of your material, which is an awesome material. I mean, so when you're building biologic with around dental implants, it's all about details. And you saw that in 2008 with the human histologic study from Myron Evans, you could see that you have connected tissue against your connecting to your titanium. So connected tissue will react. Bone will react. Epithelium will react. So make sure you elicit the right reaction by exposing them to the right surfaces. That's one of the most important things. And one mind-blowing thing, for you to even get closer to the power of the surface nano roughness, let me just share with you this article. And this article from Lee, Jung, and Kim, this is amazing because it was the first time they could get from human stem cells, they could get them differentiated into neurons without chemical inducers, not even one. What, what they did was just to expose them to a certain nanoroughness, in a certain surface with a certain nanoroughness, which is absolutely incredible. And they could differentiate it into the most difficult cells for you to obtain, neurological cells. So let's go ahead and see some of the cases that I brought you here today of the one protocol. What can we use this one protocol? That's the first question. Probably one of the most uh, disturbing questions. And I would say that primary stability is very, very important. I would say that you need at least an insertion torque of about 25 newtons per centimeter to do it. So a good primary stability, but not always. Primary stability is mandatory in single crown, but not so important when splitting implants. If you're splitting implants, then primary stability might not be that necessary. And this is also very important. Let's see one of the cases, a regular edentulous ridge. You can see that you have mobility almost to the top of the crest, so you can do a slightly lingual incision. This was a relatively easy case, and you do a full flap, a full thickness flap, a lingual incision for you to displace some of it, some of your mucosal to the buccal. Just go ahead and prepare the implants sites, replacing two implants here. I use a lot this low rotation, no irrigation bioprep because you can recover a lot of bone for the patient, and that might be useful afterwards. We're now placing our implants on a regular edentulous ridge. We remove the transporters of the implants. In this case, in this kind of implants, we also use MegGen implants beyond BTI implants. And now you're placing your implant extender. So this is the transepithelial abutment. You're placing it right away. And after doing it, you should torque it with 35 newtons per centimeter, which is going to be difficult if you don't have a good primary stability. That's why it's so important. And you have them in place. You can now go on and take the impressions as I've been do all the surgical biosealing with the PRGF and the red. It's a very, very useful tool. We just suture it not to close the wound, but just to keep everything together until we get the final restoration done. We're taking a bite, and this is the CAD CAM design. And we can now intervene in the design. I find it to be CAD CAM. It's probably one of the most magnificent tools that we got nowadays, because we can now be at close contact with our lab. And you can see it done, a close-up view of the restorations. And then on the next day, sorry, you place the restorations, you torque it, and your patient is good to go. So this is as healing goes by. Beautiful healing usually on this surgeries, because probably zirconia, it's the best material for you to make tissues heal. So it's beautiful healing as time goes by. It was 2 years. I think I got pictures and I put them here. Exactly 4 years. Meanwhile, we've done the crown on the molar and a crown on the premolar, and we just took it off just to see how it was. And it's beautiful. You're looking at the abutment. Don't forget that. You're not looking at the implant. You're looking at this occlusal allows you to see the abutment, not the implant. So the implant is well underneath that. This is one of my favorite topics on the one protocol, because as you're providing the final restoration, you're providing also to your implants a rigid and effective, a more stiff splinting of the implants. So you are enhancing primary stability. It's not so important, because even if the patient chews on it, it's going to be. And by the way, you should provide the right occlusion. I don't want infra occlusion. I want the right occlusion, because that's one of the questions I get asked lots of times. And there are a couple of articles that show us that having occlusion on immediate load, it's a good thing. It's a very good thing. And in this case, I anticipated not having a very good primary stability. Alias. I tried to go, as you'll see, in this case, it was two splinted crowns. They were all the time discementing. You can see a fistula over there still. And I tried to go for a socket shield, but I was not able to. The buccal part of the socket shield started to move, so I had to go for the total extraction. This is the ice cone technique from Tarno. I used the ice cone technique here from Tarno, and I placed the implants and the implant extenders with not the primary stability that I would love, that I would to have. But still, I thought that if I put there a final restoration, I would perform much better, and it would be less risky than if I didn't. And so that's what we did. This is 3 days. This was not next day, because the lab had to do it was over the weekend. So it took me 3 days after implant placement, and 3 days later, look at the healing. You can see the fistula still, and the healing is beautiful. 3 days later, I'm placing the final restoration, and this is 3 years later. Look at that buckle. 3 years later, it's you get magnificent results, because it's so close to natural. It's so close to natural. So splinting, get extra splint from a final restoration can enhance your primary stability, and this is very important, because we know how important it is to have immobile and primary stability. In this case, we did a PET and a tricky region. We all know that these regions of the inferior incisors, we almost always get huge collapse. So, and it's a very difficult collapse to, it's not aesthetic usually, but you get collapse and it's a problem for our patients, as we know. So in here, I decided to, some fractures, mobility, as you could see, I decided to go from some roots of immersion and also I decided to go on socket chill on some of those roots. One of them was the canine, as you're seeing. This is the Megagen kit from our good friend Mitzias, and it's the partial extraction therapy kit, the root membrane kit from Megagen, and we're extracting the lingual part of the root, preparing the site for our implant. This is a Megagen implant into place, placing the implant. And we did pretty much, look how deep. I always like to highlight that, because for you to get implant extender concept and you have having bone and eliminate implant abutment junction, that's very, very important. Placing the other implant equally as deep or almost the same as the other implant. We did the root submersion, as I told you, and placing a third implant. Placing the third implant. This case was tricky because one of the teeth was lingually placed, as you saw. I was even afraid how it would heal by not putting any graft, but I decided not to put any soft tissue graft and wait. Sometimes it's a good thing to wait for healing. And there you go. You're not seeing the implants connection. You were seeing the implant extender. You were seeing the abutment. CAD-CAM design. This is the provisionals because the patient didn't want to go without teeth. And even for 3 days, there were the provisionals, which allows us, and this is the final ratio, the provisionals, this is very important because on immediate lobe, if the case is a bigger case, I do provisionals the same way, but I just use them for 2 or 3 days because they are a diagnostic tool. If I have a position that I want to correct, if a tooth doesn't look like right, I can correct to the final restoration. So it's a diagnostic tool. I go through the provisionals as well, but they just stay there for 2 or 3 days, generally in bigger cases. In bigger cases, small cases, the same day. And this is 3 years after placement. And when you go through the CBCT, you can only imagine why you didn't have collapse on those tissues, which is a tricky area, the inferior incisor area, because you allow biology to work in a beautiful way and make it work for a long time. This is an aesthetic area. From a lateral to canine, we had failing crowns, fractured roots, the usual stuff at the anterior. We did some of the socket chill. You can see this socket chill on that central. You can see that even the socket chill, we used 2 parts of the root because the fracture was longitudinal. It was at the buccal, but instead of extracting, we used the 2 parts of the root. There is a very interesting article from Erzler doing so. And we go, our same day provisionals. And meanwhile, after 3 days, we go ahead and we take out the beautiful thing of this surgery, it looks like 3 days later, as you didn't raise any flaps, it looks like you did nothing. It looks like you just did nothing. So you can see the implant extenders, and now you'll see we're placing the final restoration, and it's the way it heals, the way biology behaves. It's amazing. It's really amazing. You get to see beautiful healing, and this is 1 year after. So 1 year after, you get all this beautiful and stable healing, and you know that your implants are well underneath that because you have the implant extenders, and only then the implant. Well, we are so thrilled with this immediate load protocol that we took it to the next level, and we are now doing full arches. Full arches is a lot trickier, uh, mainly because you have to control facial position of the teeth. You lose references, so you must have a lot more experience, but it's been a beautiful experience along the way. And the provisionals, they serve as a diagnostic tool, as you can see. So we took this patient on provisionals. This patient in particular, we only put the final restoration, I think it was like 5 days later after the provisionals, because the technician could do it in 3 days. He usually can't. It was a full arch, and so he took 5 days to finish it. You can see some of the healing over here, beautifully healing. And just before placing the final full arch, one side of the mouth, the other side of the mouth, and in fact, it heals beautifully. We have now the zirconia full arch. We screw it in, and you got all, you can see the provisionals on the left, the final restorations on the right, and you can see how it beautifully heals after placing the full arch, and the patient is smiling. Just pay attention to this little detail. When you see it from the gingival, please see that the zirconium has not been glazed on the gingival surface. Look at this zirconia, it's not glazed on the gingival surface. You can see it in this full arch. And guys, it was really, and this is how it looks a couple months later. This is really a pleasure to be here. And this is what I think I'm on time. I like to be on time. I don't know how much did I do it? Did I do it on time, or
Yeah,
just
actually,
a little bit more?
you're 100% on time.
So I'm not British, but I like to be. Omid has asked me to provide a 45 minutes lecture, and so it is, and it's a topic that I really enjoy. Hope you guys enjoy it as much as I've been. It's been quite a traveling doing this one protocol. It's been an amazing surprise, and I know if you try it, you're going to be at least as surprised as I've been.
Thank you so much, Filipe. Me personally, I have to say I truly enjoyed it and also learned many points from your presentation. I'm pretty sure all the audience did. And you know, I have actually some questions in my mind because I think it really helps to get the concept better. And regarding one abutment, one time that you mentioned, and if I'm right, the abutments that you presented was kind of multi-unit abutments, right?
Exactly.
Yeah.
Yeah,
So
they have. If you're talking about the Megagen abutments, their name is multi-unit abutments. From BDI, they call them multi abutments, but they are multi-unit abutments.
Yeah,
And
exactly. And
that's the
with actually they have different heights, so make it easier for the practitioner to decide which one is proper to choose. So my first question is this, because when I notice your cases and you beautifully showed the importance of biological width and the distance of the tissue height that we need to have for the plaque zone, for the adherence zone, for the biological width, for the emergence profile. And we know that 3 to 4 millimeter is a good number. If we can make it higher, maybe it's good. Some people say more than 4 millimeters, maybe it increased the risk of pockets formations. But regarding what you said, that one abutment one time make that tissue adherence very strong. So I think even a little bit deeper than 4 millimeters won't be a problem for us with that concept that you mentioned. So my question is now, when we want to start doing this concept and place a multi-unit abutments, what's your criteria in choosing the height? I mean, in some cases, you mentioned that you can go deeper and you place your implants even below the bone crest. So in choosing the proper height of the multi-units, what's the proper height for you? What should be the highest level of that multi-unit stance? I mean, regarding the free gingival margin position. Should it be at the level, should it be 1 millimeter, 2 millimeter below the gingival margin? What should be the criteria for choosing the proper height of the multi-unit abutment?
That's a beautiful and super clever question, as I would expect. And it's very important that you get that clear, and all that you said about the biologic width and the the difference that some authors said that going further than 4 millimeters could be a problem. It could, before we knew what we know about the nano roughness.
Yeah.
One of the things that you have to bear in mind is, if you are approaching a case which is an edentulous ridge, if it's an edentulous ridge, and this is very important, that's why I thank you to bring it up. The question, if it's an edentulous ridge, as you saw in one of the cases, what is guiding the height of my multi-unit abutment, let's say, it's the previously measured thickness of the soft tissues, which means that I'm not going to be placing, normally, I'm not going to be placing my implant well below bone crest. I'll try to have it a little bit below bone crest. That's my personal preference, and that's even where Linkovich's with his new studies is getting at. So I would take them slightly below the ridge, but he can do it, and I brought it on purpose. One of the cases, it was practically on top of the crest, so it was even with the crest. And I chose the abutments in a way that there was those abutments that you saw. They had 0.5 millimeter in height. Then they can review the conference, and they will get to see they had 0.5. If it's possible, I want my abutments to be like 1 millimeter below the mucosa. So it's mandatory that I have a mucosa, like in that case, of 3 millimeters. And if I'm using it to 0.5 millimeters, I will have a room of, let us say, 2.5 millimeters to have a little bit of connective tissue attachment that's going to be going into the abutment. And even if I place the zirconia crown even maybe to the crown. So that's very important. Initial thickness of soft tissue in edentulous ridges. When you're talking about post-extraction implants, well, that's another story
Mm-hmm.
because I really like to go deep. So I'm using, unless I, because of the dimension of the socket, because sometimes that's an issue, and the dimension of the implant that you have, because sometimes you would need like a 20 millimeters implant to get anchored. You don't have that. So you have to play with what you have. But I like to go, I would say, at least in between 1 to 2 millimeters below bone level. So the vast majority of the multi-unit ones I'm using is like, and if I'm using Megagen, for instance, it's like 3.5 and 4.5. And if I'm using BDI, I'm going to be in between 3 to 5 millimeters multi-unit abutments. Okay. So that's why it's so important. There is another thing which is very, and it happened to me once in this one protocol. I didn't bring it because we didn't have time. Sometimes, and I think it was the only time, I had a bit of a recession and a bit of a multi-unit exposure. It was a multi-unit that had 3 millimeters in length,
Mm-hmm.
and it had a slight exposure. Well, it was easy. I just changed it.
Mm-hmm.
That's why I like to call them implant extenders. I changed the multi-unit to a 1 millimeter, and I got my zirconium crown coming from all the way down from the epithelium to the top of it. So I would say that most of the time, in post extractions, I would go 1 millimeter below bone crest and below also shield, the shield,
Yeah.
the partial root that you left, that you leave there. Also, at first we left with the Baumer and Erzler, we left like 1 millimeter, 1.5 millimeters of the root coronally. Now we grind it down just till bone level, and so it's the reference.
So
I don't know if I answered the question
I got the
completely, but
point.
thank you for the question. It's very important.
Yes. So if I summarize it, you prefer to place multi-unit abutments about half a millimeter below the bone, and the top part of it should be about half a millimeter to maximum 1 millimeter below the soft tissue margin. So that's the criteria for choosing the socket
Exactly.
height. Yeah.
It's perfect. I'll make that slide and put it on my presentation next time. It's perfectly displayed. That's exactly that.
So,
Thank you.
so just one more thing that you mentioned. In one case, you said that you face the exposed multi-unit abutments and you changed the height of it from 3 to 1. So,
Yeah.
so you will be forced to change the crown, right? Because you cannot change the
Exactly.
crown again.
That's the risk of the, but it's that's why you should take it and you should anticipate it and take it on very calculated situations. Okay, it's very safe, but it's as in all procedures, you have to control a lot of stuff.
Yeah.
So that means a lot more money because you're going to be spending 2 crowns instead of one. So that's important to highlight also,
And Philip,
to be aware of those risks.
one more thing regarding the diameter of the multi-unit. Do you prefer to use the narrow diameter, or do you have any preference about regarding the diameter of that multi-unit?
I like to use the regular diameter of multi-units. That's a very, very nice question also. Even if you go back then in my presentation at the low inferior incisors, I didn't want to get into it because it would be longer, and I had 45 minutes that I had to be very very precise about. And if you sometimes you can get issues and lower incisor area, for instance, if you have contiguous implants, a regular multi-unit can be a problem. And in that case, it was. And if you go back, you can see that one of the multi-unit abutments, it was not multi-unit. It was an octa abutment. It was on Megagen. It was an octa abutment just because it had the exact diameter not to touch the multi-unit that was next to it.
Yeah.
So it's a very, very important question. And when you're short of space and you're placing contiguous implants, that's something that you have to bear in mind, and it's very, very important. But I usually prefer regular multi-unit abutments just because studies show that in terms of biomechanically, they perform a little bit better than the narrower ones. That's just because of that. A
Yeah.
little bit better.
Yeah.
So it's and also you have just one multi-unit platform and that's it.
Yeah.
Also to the lab and to your assistants, and it's simple if you keep your protocol simple.
Exactly. And I noticed in especially one of your cases in the maxilla that the level of the placement, especially in I think tooth number 8, comparing to 9 and 10 or 7,
Yeah,
it was deeper. So I want to know different depth of placement in the case of multi-units. Will it make it a problem in the future or no? Because in normal apartments, the recommendation is usually is to try to make them in the same level as possible. So I want to know your experience on the multi-units and that.
that's also a super question, and I thank you again to bring up. The thing was, and it's very important, one of the implants, the one that was deeper in the maxilla, as you mentioned, it was deeper because I get the lock that I wanted. And it was the longer implant that I had of 15 millimeters. And so I didn't have the primary stability that I wanted. And so that's why even after the implant extenders, even after the multi-units, you see that one of them, especially one of them, was way deeper than
Yeah.
all the others. But that's why, because to reach proper primary stability, but I don't see it as a problem.
Yeah.
I don't see, as you saw, healing, and sometimes it happens on post extractions. So I don't see a problem, but I think it's easier for you to have them leveled, and that's the way you should go to try to to have them all leveled. Of course, you can place, for instance, in that case, you can place a central incisor, could be 1 millimeter deeper than the implant on the lateral. If you have it that way, you will put a multi-unit of 1 millimeter higher than the other multi-unit and trying to level the case. So that's a very very nice question. If you can level them, it's going to be better, and depending also because specific morphology of the site can be different. So you can use a 4.5 multi-unit on a central, for instance, and the contiguous lateral. Well, for you to get the connected to adherence that you want to your abutment, you might have to choose 2 millimeters lower because we have the specific morphology of the location. So it's you're going to choose them. I brought it up because it's an important moment. The moment you decide the length of your multi units. you must think of it as a very, very important moment in the surgery,
Yeah,
because you don't want to go back and change them. So you must be as precise as you can, because you don't want to go back and change them.
exactly. That's a very important. And sorry to ask so many questions because your topic was hot and this is hot seat. So I just,
No, come on.
yeah. So
Very, very nice questions. I mean, I'm happy to be here.
thank
I
you so
mean,
much. And I have only one last point to mention, and that's about the articles that you mentioned by Ron Nevins, and you also referred to the of one abutment, one time, and multi-unit abutments, and regarding the fiber attachments perpendicular to the abutments in one abutment, one time concept. Um, and also, I have to say that you mentioned about the non-roughness surfaces, that how they help, because I believe that Ron Nevins, when he published the first article, it was on the laser lock abutments by BioHorizons. And those roughnesses, they showed
exactly.
how the yeah. So I want to know, are other abutments, multi-unit abutments by different manufacturers, have the same roughness like the laser lock surfaces? And can we say that if we use the one abutment, one time concept with multi-unit abutments, they work the same as those with the laser lock surfaces? Is it specific to that system or surface, or just by placing them at the time of surgery, we can expect the same results?
Omid, that's the best question you asked. I just love that question, because that's one of the most important things. I didn't get into it also because it would make it longer. Uh, that's one of the things that we as surgeons in implant dentistry, we should be looking at. It's not only about the implant nowadays. Your abutments, which are the extension of your implant, are so much more important than they used to be. So we must ask the fabricants when we choose our implant brand. It's important, it's so important that you know two things. You should know the micro gap, and I mean, I refer to the static micro gap and the micro gap under load, which are two, two very, very important things. And also, you must know the nano roughness of your abutments. That's a very, very, very important question. And so I would say that there are a lot of brands. I even, it's a funny story, because even before I started using Megajam, uh, that was the question that delayed my decision to start using Megajam, because I asked, and when I got the answer from Professor Wang Park, it was very nice to know that the abutments were within the biological limits that I wanted them to create that fiber organization.
Mhm.
So it's a very, very important thing. And the study that I talked about, and that you mentioned from Myron Evans, is exactly laser lock. The study was done on laser lock implants. And he even found out in that study, and that's why it's so important that the connective tissue fibers get organized on a perpendicular way. He found out that you could have vertical bone growth, even if you could get the right action to and then he found out that later in animals also on the abutment study. And I'm waiting eagerly from a study with human histology, the second one that I presented. It's very, very important, because you can influence bone uh, beyond what you thought. before. So the abutments and the nano roughness, no other brands, but you can't extrapolate the results if you don't have the right nano roughness. So it's important for you to ask the brand that you're thinking of adopting if the nano roughness is right. You know that from BTI and from Megagen, I know it's right because they have just the dimension that allows a molecule of tropocollagen to be inserted into that. That's another question which would be much more detailed and boring, but it was one of the topics that I studied the most before using this kind of protocol.
Thank you so much, Felipe. I have to say, I truly enjoyed these gaps with you and truly enjoyed your presentation. I'm pretty sure so many of us have learned so many things, and at least it was an update for all of us. And I believe that the concept that you mentioned and the details regarding the protocols that you brought us really help us to, as you said, go to a next level. And when we do it, we really get how exciting that's going to be. Thank you.
Yeah. Thank you so much, Omid. It was a real pleasure being here. And I hope you guys have a wonderful 2020 and just be safe and be sure that it will improve.
Exactly. Stay safe, my friend, and really hope to see you very soon. And thank you again for your time and for everything. God bless you.
See you soon. Thank you.